Good afternoon, everyone. So, we are going to have a session on decreasing spectacle dependence by the approach of cataract refractive surgery, and this is aimed for general ophthalmologists. So, we have on panel here eminent speakers who will take up each topic and try to make this transition easy for you. So, I'll take up the first topic, which is the choice of presbyopic IOLs in current scenario.
Dr. Parul is a very prolific cataract and refractive surgeon. She's head of department at Max Hospital, Gurgaon.
So I think more and more cataract surgeons now are aiming to make their patients less dependent on spectacles most of the time. So it's not an overstatement when we say that currently cataract surgery is perhaps the most common refractive surgery now. And we've seen the evolution in all the presbyopic lenses where we started from a simple refractive bifocal to where we have come now, and even most of the lenses have toric incorporate in them now. So despite the evolution of presbyopic glasses, our patient will still have those little problems which make us deter and be wary of the presbyopic lenses. And that is the aim, to give you the choices where you do not end up spending so much time, energy, and your patient is spending that cost and still saying that it's not so good, doctor. So what are the choices? There are quite a few choices out there. And how do you select which kind of presbyopic lens would work best for your patient is what we are going to take up. But before that, in choices of IOL, we've come a long way since we started with refractive multifocal, where the limitation was that they were pupil dependent, they were sensitive to centration, would cause a lot of decrease in the contrast sensitivities and halos and bursts. So we move on practically from this stage to the diffractive multifocals, which are less pupil dependent, not so sensitive to centration, and the amount of halos and glares has also become much less with the finesse and the technology which the lenses have adapted now. The other, the spectrum is the EDOF lenses, which are very popular now. They are based on either inducing a spherical aberration in the center or having a raised platform or a wavefront technology. You also have the extended range of vision, where again the idea is to stretch the wavefront, which shifts the light to give an extended focal length and hence a continuous range of vision. Then is a category where they're doing a sandwich, a mixture of both diffractive and EDOF kind of lenses. So you have diffractive hybrid IOL, or you have a diffractive refractive multifocal hybrid. Again, all the modifications to improve the performances of these presbyopic lenses. So to touch upon the modern ones and the ones available in the market which we are using, this is a very favorite lens of a lot of people, a PanOptics based on the diffractive trifocal technology. Again, a similar concept by Zeiss. Then you have the wavefront one, the VVT one, that's been on the extended range of vision, which I said is the wavefront stretched thing. Minivel is a progressive EDOF lens, where the positive spherical aberrations in the central 3 millimeter zone create that kind of multifocality. Synergy is a hybrid between a refractive and a diffractive lens. Here they have combined the posterior diffractive multifocal with multiple rings and a central EDOF zone. They've also added an achromatic technology, and the company claims that we have a better resolution edgelet. And with advanced lathing of these diffractive rings, the total amount of scatter and the total amount of glare and halos is less. Another example of a hybrid refractive lens is the Lucidis, pretty much based on the same principle. And another lens not to leave behind our Indian companies is Suprafob in focus by Appa. It has a small central zone for near vision, a plus 3.5 mid peripheral, and an intermediate. Claims to be less independent on dependent on the pupil. So a lot of people till now were confident about only the imported lenses, but recently the India market has become very hot, and in peripheral centers or your patients who cannot afford very that kind of cost bracket, these are good lenses. I have personally just use Supraphore and Magnifend, not much experience. So we look forward to the other speakers sharing their experience, but they are turning out to be good one. AIOCare Naturopan Focal is to be launched soon, and this one claims to be giving a much better contrast in distance vision, and also much less halos and glare. So let's see where this all takes us. Not to forget one bracket where you're transitioning. This is a safe lens, which is like an enhanced monofocal, so it gives you both distance and intermediate. No downside to it except for doesn't work in astigmatism of more than 0.5, 0.75. So if you are transitioning from monofocal to multifocal, this is probably safe bet. So after this overview of all the presbyopic lenses, basically the question is what your patient wants. All patients would want, dependence from glasses most of the time. One thing which has changed in the post-COVID, or the, let's say, from past few years, is the digital shift. So earlier, how with bifocal, we used to only focus on distance and near. Now it is a continuous range of vision where the intermediate tasks have also become very important. So how do we choose the lens, right? We talk to the patient, because it's not about fitting any lens in any patient. You understand their visual needs. This also gives you chair time to talk to your patient and understand and build up that rapport with the patient. Choose a established predictive outcome. So for example, if I've shown so many lenses and they've not been tried and tested, you don't want to burn your fingers by trying anything new. So rely on the colleagues who have used these lenses, take a feedback from them as to how their experience was, and then start your practice on that particular lens. How do you select the profile is select patients who are self-motivated. You don't want to waste too much time in pushing the patient to have a presbyopic lens and then have a patient who's not so happy with the results. If he's an avid night driver, I'm talking about initial selection. Later, of course, it doesn't matter because you have EDOF and other choices, but you would, want to keep this kind of patients for your later practice. Better to do bilateral implants, because then the outcome and the neural adaptation is much faster. Clinically, make sure that they have no ocular surface disease. Make sure that you treat the dry eyes before you do the presbyopic lenses. Corneal topography is very important to rule out any kind of irregular astigmatism, because that affects your visual outcome. See the astigmatism very carefully, and our speakers will talk about planning of that also. And initially avoid post-refractive patients because of their irregular corneas and problems in calculating, which we will also touch upon. So patients to be avoided. Somebody who's very happy to wear glasses, why push him not to wear glasses? That's okay. Very aggressive type A kind of people, or people who have mental health issues, who are on medication, bipolar, schizophrenic, you would want to avoid these lenses for them. As I said, very avid night drivers in the initial part of your practice, irregular corneas, severe ocular surface diseases, and macular pathologies, you do need to do your OCTs to find out any fine ERMs or drusen's which could affect the post-operative outcome, and also post-refractive eyes in the initial part of your practice. Based on ocular condition, as this is a repeat of what I said, pseudo exfoliation, zonular laxity, you would be wary of doing presbyopic IOLs initially, because the centration is very important. Diabetics patients can be taken up for presbyopic IOL if they are well controlled. It's not a contraindication. Similarly, early glaucomas are not a contraindication. Fine ERMs, very few drusen's which are familial, non-progressive, again can be taken up for presbyopic. Low threshold initially, keep patients who don't have that much astigmatism. Only once you're comfortable with presbyopic IOLs, go on to toric presbyopic IOLs. So choose your patients, and you can manipulate your biometries on a toric planner and take incision on the steep axis for small astigmatism, or keep them for later LRIs. Can you take up one eye cataract, one eye monofocal lens done? And the other eye patient wants a multifocal lens. Yes, I've done a few patients. You have to explain them about neural adaptation, but it won't be a perfect situation, but they won't be looking around for their reading glasses for everything. So you can do a mix and match if your patient is ready to adapt, and be okay to have top-up glasses as and when required. So this is very important, as I said, to talk to the patient to understand what their occupation is, how much distance they need, what intermediate work they are doing, how much reading they are doing in the night, how much night driving they have, and if they are open to having used glasses for any small refractive residual error. So if you have that kind of discussion with your patient in detail, then post-operative patients, you won't have them so unhappy, or they are already mentally prepared. Also see their cost affordability. As I said, don't push them, but don't even judge the patients, because sometimes you just look at the patient and you feel that, oh, probably he's not the presbyopic IOL or the premium IOL kind, and you don't offer them, and later patient feels very cheated, and his neighbor will not be wearing glasses and he says, doc, you haven't given me that option. So we give that option to everybody. We have a ready format of all kind of lenses, and once they show their interest, then we have a detailed discussion. So I'll just summarize by giving a broad comparison between diffractive and the EDOF lenses. Which one would you want to choose on? So if your patient wants a crisp, good distance vision and excellent near vision, the diffractive IOLs, the patient is able to hold objects pretty close also, and in good lights they do extremely well. I would choose a diffractive lens. If you're doing too much night driving and young patients, then I would choose an EDOF, not so much diffractive. Again, if the patient has type A personality or other mental health issues, probably my go-to would be an EDOF lens, because that's more forgiving, and I would not do a diffractive lens. So for beginners, the EDOF is more forgiving. It has less halos and glare, but the only challenge with EDOF is sometimes you may need a top-up glass for very fine reading, or patients who are used to holding very close objects. So it gives excellent distance vision. Intermediate is very good, but for very fine, you may need top-up glasses. You can also do a micro monovision, because that's what we do in our EDOFs and VVT. So one, we aim as close to zero as possible emmetropia, and other, you can keep the next myopic on your biometry, like a minus 0.25 or a 0.3. So that is a broad comparison in choosing the type of presbyopic lenses. The last slide is on what kind of cases to choose if you're starting your presbyopic practice. Is hypero presbyopes. They are the most happy with whatever they get, minimal astigmatism. Again, decide on the visual needs. I've given you an idea of how to choose, preferably bilateral, because the neural adaptation is much faster and they are happier that way. And as I said, you can, if there is a small residual error, your biometry is a little off, you can do a micro monovision correction in the other eye, or plan whichever way to balance out the other eye also. And do not burn your fingers by missing out something on the OCT or something on the corneal topography. You may have chosen the best of lens, done the best of surgery, but you will have an unhappy 6/6 N6 because you've missed out a comorbidity. So with that, I will invite the other speakers. The presbyopic IOLs are still, work in progress. So they'll keep getting better and better. It's a journey, but we just have to be careful about how we plan things. So you're saying if there is anything residual and you want to do LASIK on top of it, you can, and we will do. Suppose it's very off, because usually when you are planning premium IOL and multifocality, there's not a much of a gap. It's a very small residual error, and you always have two eyes to play with. So usually we try and compensate it with the other eye as and when possible. Give spectacles meanwhile. Only for a very gross thing would you want to do a LASIK. So touchwood, I haven't felt the need, but yes, it can be done if there's been a calculation error, or something very gross, or if somebody's patient has come later. And those are smooth transition profiles. So the way we choose a presbyopic lens on a multifocal platform, so you go to using your True Barrett formula and look at your EKR holiday. So here it's a reverse calculation, but probably that's the only way forward if the patient doesn't want to wear glasses. Yeah.
No, I think you need to include it as part of a possibility, because see, you have promised them something. Yes, but you can tell them, I don't know how many would, unless you have your own LASIK facility and you're doing a PRK, or which is really not costing you much. But if you have to take your patient to another facility, you have to tell the patient that there may be a surprise. And I think with our the kind of biometry we do today with our optical biometers and using the latest generation formulas, refractive surprises are quite rare. But if the patient has had a previous refractive surgery, or if you're choosing a patient of an RK, which normally you would not put such lenses in them, but those are the rarer cases where you would have a refractive surprise.
So if it's your own patient and you have picked it up early, say in the first week or the first 2 weeks, and and you found out that it's a refractive surprise, if it's up to 1.5, you can probably wait and then do a touch-up, laser touch-up. If it's more than that and you have proven it yourself, then it would be probably better to do an IOL exchange. If it's somebody who has come from referred or come to you for a second opinion and maybe a few months already beyond the first surgery, then there's no question of IOL exchange because fibrosis has already set in. And then probably you can think of, but you cannot do it for a very high ametropia. I'll go.
So I'll invite Dr. Anaga Harur from Mumbai now. She's a very eminent, prominent anterior segment cataract refractive surgeon in Mumbai with a large practice, and also is one with the highest number of votes yesterday. So the podium is all yours.
Thank you so much, Dr. Parul. At the outset, thanks for including me in your IC. It's a pleasure, and I have thanks for the votes also, and for all the support. So my topic would be managing astigmatism as well as presbyopia. So these are the two culprits that would cause a blurred vision to us, both presbyopia as well as astigmatism. So a simple monofocal today is not the one-stop solution. The yardstick is the 2020 youthful unaberrated human eye, which obviously we cannot meet, but we plan to meet. And the holy grail today is to give good far, good near, and good intermediate vision. But the challenges are not only in patient selection, but what kind of lens they would put, good patient counseling, and a precise biometry and surgery. Like Dr. Parul has already mentioned, the first thing that you do in a patient for a multifocal workup is even before you touch the eye, you need to do the biometry. See that the cornea is pristine, no anesthetic has to be put. It should not be a patient where dilatation has already been done, though I know in very busy practices, and if a patient has come from very far away and cannot come back again, sometimes we end up doing it, but that's not the ideal way. And if you're planning a multifocal, then you should call the patient back. So in our practice, we make it a policy to repeat readings at least twice, so that you ensure that these readings are repeatable. Also look at the ocular surface topography, especially if you are planning a toric multifocal and OCT macula, and also look at the scotopic pupil. So we already have seen how you can choose a suitable candidate, and a person who asks too many questions is too finicky and has going to keep coming back to you. And always ensure that you have a relative along with the patient, and explain to the relative also equally, so that he understands what exactly the patient is going through and what he can expect. Avoid patients who are regularly driving at night, very cynical, hypercritical patients. Now, patient, for example, like this, you have to do a complete good clinical examination, slit lamp examination, and look at this. If it's an irregular astigmatism, and that is why topography in these patients becomes very important. You could have a corneal wavefront which is showing a vertical coma like this. So even if there is an EBMD and you have not picked it up, especially if it's a dilated pupil and advanced cataract, sometimes it's very easy to miss these patients. So you can go really awfully wrong, and these are red flags. Something like this, which is causing irregular astigmatism and can affect your visual outcomes. Now, this was a 65-year-old patient, and that is why what I meant was, when you do 2 or 3 readings and you see this variability in the K readings, it was basically a patient who was a chronic diabetic with a poor ocular surface, which will lead to discrepancy between the instruments also. In all our patients who have been high myopic, also ask for history of contact lenses, and then ensure that they are off lenses for at least a week before. Criteria for exclusion are all these. Preoperatively look for changes in the cornea, macula, optic nerve, if there are any traumatic history of trauma, if there's any zonular dehiscence. Large angle alpha, which also probably it could be a hype, but if it's a high hypermetropia, then you need to be a little careful. And intraoperatively, if you have a significant PC tear or a zonular dialysis, you have to take a lot of precautions. Now, coming to management of preoperative astigmatism. Earlier, it was the general practice that probably less than 0.75 you go in for a plain multifocal and beyond that. But I have moved away from this, and I'll tell you what I do, and where we discuss options of toric multifocals depending on the affordability of the patient, or use femto relaxing incisions or LRIs, and probably, as we discussed, laser correction in the second procedure. And yes, like we said already earlier, if there is a misalignment of the toric lens, why is it extremely important? Is if there is a problem in the capturing of the data, if your keratometric reading is imperfect and your alignment is imperfect, then you are bound to have imperfect visual outcomes, and you need to be very wary in these patients. Even ensuring that as I said, data capturing, if it's a tilted eye, then you can see how a 1.74 has changed to a 1.9, and this itself can induce astigmatism. So which is the best IOL for my patient? And today we are spoiled for choice, and we end up being a matchmaker, like Dr. Parul has very clearly defined to us. So now let's see a few scenarios. This is an against the rule astigmatism. Now I am here showing no financial interest. I am here showing some cases which I plan on the Varion, but you can easily use the online Barrett toric calculator for this. Now look at this patient. If you can see in the top, the cylinder is around 0.47. The flat axis is vertical. So it's the against the rule astigmatism patient. This patient has come to us for spectacle independence for cataract surgery. It's a 0.47. How many of us would use a plain toric multifocal for this, patient? If it's a 0.47, conventionally we would say yes, why not? Because it's even less than 0.5, right? Now let's see what happens. With a 0.47, if I actually go and plan, and I'm not considering posterior corneal astigmatism, and I plan the eye, the treatment, and look at what the expected outcome says in the yellow. The cylinder which is residual going to be at the end of surgery is 0.93. So a 0.47 has changed to a 0.93, which is, I think, quite high if you are planning a plain. That's what. I'm just coming to it. So here you can see the SI is 0. Now, if you have a 2.8 millimeter incision, like I'm showing there, SI is 0.3, it comes down to 0.63, which is also not very less. So you can plan, you see here I've taken a non-toric, the TFNT00. That's a non-toric trifocal, which is giving us a residual outcome of 0.63. Now what if I choose a toric, which is the next one, and look at what happens to my residual astigmatism is 0.02. So which is better? Why should I leave behind a 0.63 when I can upgrade to a toric and get a residual of 0.02? That is for us to decide depending on how much perfection you are aiming at. So this was the first. So this was the T20 that we are taking, and we are leaving behind a 0.02. Now, suppose you don't want to do this, and the patient says, I don't want a toric trifocal, I cannot afford it. At the same time, I want spectacle independence. What is the next thing you can do? If you opt for the paired arcs, as you can see here, so there are these paired arcs that you can put, and if you're using a femto, you can use femto relaxing incisions, and then again, you can achieve a 0-0. That means you can do one of the two. Both can work. So this was a patient whom we had done like this, and we finally achieved good outcomes. Now let's see another scenario which is with the rule. As you can see here, it's a 0.67 and flat axis is at 9 degrees. So it is a with the rule astigmatism. Now if I consider the TFNT 100 and no arcs, so what is the 1 minute. So this is a 0.67. 1 minute. Is this the same thing? Yeah. Look at the cylinder that we are leaving behind is 0.19, and I'll just go back to this. Yeah. This is the 0.67 minus 0.67 cylinder. Flat axis is 9. So it's a with the rule astigmatism. Okay. Here without the arcs, see what is the residual astigmatism is 0.19, right? So you don't need a toric here. Now with the 0.67 here, with the plain trifocal and with an SIA of 0.3 when you are adding it, it is 0.47, which is okay. So you can go ahead and put in a non-toric. Now going to an oblique one, again a 0.67 with a residual you can see here of 0.79 in the yellow. What would you do? Would you use a toric or a non-toric? If you are putting in an SIA of 0.3 with a 2.8, you are getting a cylinder of 0.58, which is okay. You can still go ahead with a non-toric. And if you plan a toric, that 0.58 can be reduced to 0.0. So again, that is a call that you can take. So what you need to do is basically go into your Barrett toric calculator, or if you have access to a Varion, put on this data and explain to the patient, and you yourself can know whether you want to go in for a toric or a non-toric option. So these are the various ways that you can actually go ahead and do. Now, since we are talking about treating astigmatism along with presbyopia, if you have a digital overlay, that's fine. Otherwise, you can still do a very good job using markers system like this. And surgical pearls, you need to have an intact capsular bag, a good perfect CCC, a femtorexis would be even more ideal. And what you need to have is a good anterior capsular rim all around, and wash off the viscoelastic from behind the IOL, because here you are planning a toric, you need to align it perfectly at the place where you want it, and you don't want it to rotate. And the most common cause of rotation in the postoperative period is residual viscoelastic underneath the lens. So this is what is extremely important. So the same thing, you can do it without the femto. So this was the patient where we had done the femto-relaxing incision also, and the patient did well. So this was the femto-relaxing incisions there. So the same things. So intraoperative exclusion criteria, suppose you have an event on table, you need to take care, keep a backup in all these patients, and you have to take the call depending on the intraoperative situation, what you want to do. So a patient comes to you with needing spectacle independence. 3 questions that we ask to our patients: how much computer work is he doing, how much reading per day, and if he's doing any night driving. So if he is doing regular night driving, then it's a very important call that you need to probably avoid a diffractive trifocal, for example, and go ahead and use either an extended monofocal or an EDOF where the chances of glare and halos are less. If the night driving is only at times, or suppose it's just once in a while, then you have to counsel the patient about glare. If for the patient, night driving is more important than spectacle independence, suppose he has to do a Bombay-Pune every night and maybe once in a while, so then that becomes very important to him. Then again, you give him a choice and tell him it's your call whether you want to do it or not. We cannot guarantee that there would be no glare and halos. Okay, if he's never going to do night driving, then definitely the chances of glare and halos is much less. You can maybe just mention it, but you don't need to really dwell on it too much. So if he's okay with the glare and halos, then the next question is you ask how much of intermediate vision the patient is doing. So here, for example, we have taken it as a computer work or a desktop. If he's going to regularly do it, then definitely you have to address it. You cannot think of using a traditional bifocal for this patient. You have to address it, otherwise he's going to be extremely unhappy. So a first choice would be a trifocal or an EDOF with a micromonovision. If he also wants good near vision, then trifocal is important. If he is okay with a reader and he just wants good intermediate vision, then you can think of an EDOF. But today with good EDOFs like Minivel with a Proxa combination or a Lucidus, you can have probably best of both. If the patient is doing computer work intermittently and is affording, still I would go ahead and do a trifocal. That is my lens of choice, because see, it's not only computer. There are so many other activities where you require intermediate vision. Here we are just taking it just for the purpose of description here. So if the patient cannot afford a trifocal, then you need to counsel. And he still insists, there are some patients, and he's not doing intermediate work at all, but you have to explain to the patient that he would not be able to read his computer without this trifocal, if he's opting for a lower package, because that would be probably the lower package in our case. So here we would counsel him regarding that. And if he's never going to do a computer work or this thing, then maybe you can go ahead and do a bifocal. But what is important is, how do you decide the near addition? So what we do in our practice is, I had an interesting patient. A patient was operated elsewhere with an IDOF, was not told that she would need a reader. So she could see 6/6 for distance. She was fairly okay for computer, but she could not read for near without glasses. And her complaint was she wanted to read without glasses. Then she came to me for the other eye, and we actually measured where she was holding it, and it was exactly 33 centimeters. So we went ahead and put a synergy, even though the principle of the IOL was different in both the eyes. Thankfully, even after completely explaining to her and counseling that the two eyes are going to be different, she accepted it well, she's happy. That's another issue. But what is important is, at what distance the patient's maximum work is going to be. You probably have to actually measure it, and then you are sure that whatever lens you're going to use is going to be fine. No matter what lens is chosen, do not make a promise for 100% spectacle independence. And yes, just touch upon the dissatisfied patient. The 7 C's is something we all need to remember. Always try to do the second eye as early as possible, so that we can have a better neuroadaptation. Residual cylinder is something which should never be left behind, and that is why so much of planning is required. And early PCO needs to be treated, because it's going to reduce contrast sensitivity. So you need to do a YAG early if at all the patient develops. CME could be missed, and that needs to be diagnosed early. Look at the corneal and ocular surface, centration of the IOL. And yes, there could still be glare and halos, because in diffractive IOLs, we know 18% of the light is going to be wasted. So counseling of patients is important. Always undersell and overdeliver. Thank you very much for your kind attention. And I always feel that our multifocal patients are like your lovely wife or like a husband. You give more time to him, and he'll make life heaven for you. Otherwise, it can be life hell for us. Thank you so much for your kind attention.
That was an excellent talk, Dr. Naga. And just one point I'd like to make, that if we cannot do a femto astigmatic keratotomy, you can also plan a opposite clear corneal incision. For those cases where you have a small cylinder, 0.5, if you want to manage, that can be also done.
Thank you.
So we have none other than our very dynamic and Dr. Chitra. No. You've given us such a wonderful year, and I think we would still like to give you a big applause. We'll cheer for you always. Yeah. We've learned so much over the years from Dr. Chitra, so we are really, honored to have her here today.
Thank you. Very good morning to one and all of you, and my dear friend Parul for giving me this opportunity. And thank you so much. Thanks for your very nice words too. If I come back for some posts, then I know who all to look to. Look at me, how I get hopeful the second day after a failure. So my due is going to be to talk on managing unhappy 6/6 and 6 premium IOL patient. Basically, unlike what was thought earlier, there's an overwhelming majority of our patients who are happy with multifocal IOL, and there are two important studies. One is the Concerto study and the Harmony study, which shows that 94 to 98% of the patients who had undergone multifocal IOL lens implantation were ready to recommend it to their friends and colleagues. So then, but we need to hit it on the target, and how do we hit that? For this, you need to see these 7 C's, whether the patient has a cylinder or residual error, a corneal ocular surface issue, chronic visual disturbance, centration, capsule opacity, CME, or is it a crazy patient? But then, we have to understand that we cannot assume a patient is crazy. We have to listen to him. There would be wealth of information which would come across, because only then you're closer to planning how you're going to do. You're going to ask him whether the lack of visual clarity is for distance or near, or is it that it comes only in the light conditions, like it's getting dark, or is it that it was clear initially and now it is getting unclear, when you wonder whether there's a CME or is it a PCO. So all of these will give an information as to how you handle it. But then when you start looking at an unhappy patient, you have to look at him right from the cornea, the refraction, the ocular surface, the tear film, the IOL is centered, what is the pupil size, is there a PCO, and how is the macula. And then if there is an issue, you need to go slow. You cannot plan the other eye. Normally, you would like to do the second eye at a short interval for neuroadaptation, but sometimes you know this patient has a specific problem. The corneal surface, you need to look at the tear film. We all know the tear film has different layers, but the reasons could be why this dry eye could be because pre-existent and we have missed it out in our workup, or it could have got triggered by the cataract surgery itself, because there is some amount of inflammation at goblet salts and meibomian gland dysfunction consequent to the inflammation which can get triggered on. In fact, there was a popular phaco study which said that 60% of those patients of ours who looked asymptomatic, in fact, had varying amount of dry eyes, and only if you do a tear breakup time or do a corneal staining, then do you realize that they have dry eye status. And why in phaco it happens is because of the nerve transaction, the prolonged exposure to microscope light, and the post-operative medications and more. And if this patient had a Schirmer's of 10 before the surgery, but after the surgery, he came in with severe dry eyes, you need to repeat the Schirmer to know what it is, and just don't look at the pre-op value, because there was an inflammation which needed to be treated. And you could even do a meibography sometimes to explain to the patient, look at your meibomian gland dropouts, and that helps the patient to understand, and he is with you all through rather than you losing the patient to some other person. Chronic visual disturbances could be anything from a positive dysphotopsia to a negative dysphotopsia, or those entoptic images. Like why is it the multifocal IOLs work on the principles of simultaneous vision? When one image is in focus, the other out of focus image is suppressed, and that out of focus image is the cause of halos. And we all know our human eyes is not fit for the visual system is not created for multifocality, because it is just that there's loss of light with these multifocals which causes visual disturbances. Positive dysphotopsia is glare, halos, scattering of light. This is because of the newer square-edge lenses and the high refractive index lenses which come. Why do you have high refractive lenses? Because we want those lenses to be thin, and those can cause positive dysphotopsia. Invariably, they settle down, but you even assuming it's positive dysphotopsia, the last option is an IOL exchange. But before that, you need to rule out there is no ocular surface issue, there's no decentration, there's no PCO, because without knowing, don't jump to remove the intraocular lens. And I'm not going to show you the IOL exchange thing. Negative dysphotopsia, it's a dark shadow which he sees on the temporal side. It could be again because of the high refractive index of the lens and the square edge, but it is also because the anterior capsulotomy margin to the IOL, there is what is called the Lambertian light scatter. Let's understand there's some light refracted and some light is reflected, which causes this light shadow. Majority would settle down, but there are 15% of them who you may have to intervene, like you could place a zero-powered piggyback IOL. You could just get the optic out and do a reverse optic capture. Rarely, a nasal capsulectomy might also be done. We need to understand that pre-op evaluation, half your work is done. We should look at the centration of the IOL. Like this looks a little decentered. In fact, the patient had a broken haptics. He had got operated elsewhere. But nowadays, one thing, good news is our central optic zone of a modern IOLs have a larger zone, like 1.16 and all that. So even if your angle alpha is more than 0.5, you could be implanting the lenses. What happens? The decentration could be because the rexis extension was there, the rexis was large, there was asymmetric back contracture, they were large angle alphas. So this was a patient who had some odd cylinder, and when we actually went and opened the eye, we realized there was a zonular weakness, and you place the CTR and optimally rotate the lens, the problem got sorted out, and we did not need to do an IOL exchange. Doing a perfect surgery is very important. A nice round rexis, a clear cornea, and do it on the femtocataract platform is an advantage. Doing a PCO, don't go and just yag it off. Look whether there's any other cause for drop in vision. Is there a CME? look at into everything and wait for at least a 3 months period before you decide to YAG, and before you know that you're not going to do an IOL exchange for these patients. You need to do a retinal evaluation for CME to lamellar hole or epiretinal membrane, anything which has got missed out, and you need to treat these conditions, and that itself would be a solution of sorts. Again, how do we prevent it all? We need to understand there would be some set who are crazy patient. You might have done a good surgery, you would have not chosen the right patient. You need to also understand the implants don't come at 0.12 or 0.25. So there could be those small residual errors which cause problems. But with the kind of biometry which we have with the IOL formulas, if you are doing right calculations, things cannot go wrong. But most importantly, how do you differentiate yourself? It is just making the patient feel that you are his friend, you are with him. And that positive reassurance helps you go a long way, because the patient is ready to wait with you and trudge that path. And we have a range of lenses now, right? From low ad to EDOF to trifocal. So we have to choose the right lens, look at the measurements, be with our technician, or train our technician if you have a very busy practice. So if you have the right patient, the right IOL part, the right kind of surgery, you'll do well. And finally, even if the patient is 6'6" exactly, but is a 6 happy patient, that is more important, and we can leave that patient alone. There are mix and match technology, there are a whole lot of issues which are there, but the whole idea of me rapidly talking to you all is, we need to, when you see an unhappy patient, this patient belongs to us, we have to take care of the patient. Think of all the possibilities in your mind and carefully rule out one by one, and then you might have actually got a solution as to how to treat these patients. Thank you very much.
Covering it so exhaustively. I know you have to go into another session, but if there are any questions for Dr. Chitra, we can take it now. Okay. So thanks, Dr. Chitra. I'll invite Dr. Abhijit Desai now to talk about how to do a presbyopic IL surgery well. Dr. Abhijit is a high-volume cataract refractive surgeon from Mumbai. He also has a special talent of doing excellent oculoplasty as well. So over to you, Dr. Desai.
Thank you, Dr. Parul, for including me in this IC. So we're going to talk about surgical pearls for a multifocal IOL. And we have to understand how to give the maximum benefit of the trifocal or EDOF or any of these presbyopic correcting IOLs to the patient. And pearls definitely develop over a period. So there are pearls with relation to incision, rhexis, pupillary centration, small pupil, capsule polishing, and the final IOL placement as well. So the incision, usually when you're planning as a surgeon, would be at a comfortable position. For me, for the right eyes, I go on slightly on the right hand side, so it's not exactly at 180, and for the left hand side, it's exactly at 0. So I make my position accordingly, and then we do the incisions. We have to be sure about not having double entries and having a good square incision to have a minimum SIA. If possible, flax for the consistency of the SIA would be very welcome. The CCC is basically very important. You would aim at a good overlap. So anything below a 5.2 or a 5.3 would be ideal, and not too less than 4, because that would give a high chance of a phimosis. Now here I am using a rhexis marker from the Varion. I have aimed it at 5.3, but I try to go below it. So I end up with a 5.2 or a 5.1. You can also use rhexis markers like Verus and other things. And usually a good idea is to have the rhexis around the Purkinje images as the center of the rhexis, and that gives a good rhexis on the visual axis rather than the pupillary axis. So inadequate coverage can give rise to decentration in post-op period. Flax gives very good consistent sizes of the rhexis as well as a good overlap. Capsule polishing is very important out here because you don't want these kind of premium IOLs to end up with a PCO at an early stage. Whether it's bimanual or whether it's coaxial is surgeon dependent. Posterior capsular polishing here, I would put it more aggressively than anterior capsular polishing, because if you polish the posterior capsule and you stick the IOL back to the PC, it really prevents long-term uh, early PCOs or even long-term PCOs for that matter. In flax, I tend to do a very good polishing on the edge of my CCC, because that is what helps it to stick to the gives a better shrink wrap and a faster one. In case you get a PCR, you always should remember to do a PCCC for the intactness of that PCR, and vitrectomy if there is a vitreous prolapse. Now here I have a PCR, and there is, if you can see, the flap is really fluttering. So there is no vitreous tag out there. I just go in and do a PCCC, and then I can put in an IOL there of my choice in the bag, and that gives a good result even in these kind of patients. Here I'm using a dialer to feed that flap to my rhexis forceps. So I try to do it from the other side. It's not happening, so I do it from the other side instead. So here you have to be very careful about peripheral PCRs, and that's the toric IOL here. It's not a multifocal though, but you can easily put it in the bag and get away with it. If it's larger than that and you don't have enough support, you definitely have to put in a monofocal IOL, and you'll have to come and talk to the patient about it and counsel them about it. Now here I am trying to remove off small tags, the plaques on the PC, because these are the ones which actually don't allow the IOL to actually stick to the PC, and that can actually give a small tilt in very large plaques. And it's a good idea to remove these. It's not very difficult because they are just about stuck there, and if you get a good plane, very easy to remove using the forceps or any sharp dissection. If you find any small signs of zonular weakness or dialysis, so that's when you're polishing and you see any movement of the bag, you would put in a zonular a CTR to prevent any future problems for the bag. And these are the patients who do very well otherwise. There are certain lenses like the Zeiss lenses which are a bit short. So if you have a big bag, especially myopes, and a big wide to wide, you would tend to put a CTR even in these patients, so that the rotation is prevented for the toric IOLs. So here, in spite of me not having a zone dial, I'm putting in a CTR because I feel that there is a zonal weakness and I don't want the patient to have any um, bag problems later on over a period of time. So IOL placement is very important. IOL centration is important. If you do not have fancy instruments, the best thing you can do is actually have the two first and a third Purkinje image coincide each other, and the center of the IOL to be taken out here. So if you can see beyond the rhexis, you can see these two images actually being in sync with each other, over each other, overlapping each other on the central optic zone. You can avoid IOLs in very high kappas. You can definitely, you need to remove viscoelastic from behind the IOL. I have changed my technique over a period. I do a hydroimplantation of the IOL so that I don't have to remove the fluid from behind the lens. And a good habit would be to also tap the lens and make the lens stick to the posterior capsule when you're coming out. So that's how you do the centration on the Varion. That gives you, this is on the visual axis. So this is how you would do the centration of the rexus without the markers, taking the central reflex as the center point of your circle and doing the rexus out there. Now here I had a irregular flap out here, and I'm trying to make it exactly circular by using a micro scissor and a rexus forceps, so that I do not have an unequal overlap of the rexus, which can lead to a problem later on. And obviously you need to have a good phaco technique. Small pupil, how small is small? Less than 2.5 millimeters usually is contraindicated, but you can tread with caution. Manage the pupil without damaging the sphincter or irregular sphincters. That would result in an atonic pupil or a eccentric pupil. So you should avoid hooks in such cases. A BHEX or a SOS Malugin ring would be a better option. So you have to be almost 100% faithful with the technology, and you should have the conviction in your advice and surgery to be sure about the results that you would give with these presbyopic correcting IOLs. Thank you.
So just one or two small comments. Dr. Abhijit is lucky that he has access to flax. But many of us who don't have access, we can still use, it's a very simple rexus marker that you get. And prior to doing your rexus, it's a metal ring. You can just ask the patient, you're doing it under topical, ask them to look into the microscope light, and you can mark your rexus on the cornea. So if you're using a 5 rexus marker, you're getting a slightly bigger 5.25 rexus. So instead of, if you don't have access to Varion or something, so you can use the manual rexus marker, and that works really very well. Other thing is that, of course, polishing is extremely important in these multifocal IOLs. So you can also do hydro polishing. So just a direct jet of fluid, and that helps to clear off all the debris and gives you a nice clear PC.
Yeah, that's a good option.
Do you do anterior capsule polishing too, or?
No, I don't do the anterior capsular polishing because it prevents a faster shrink wrap. Yeah. But in flax patient, I do it on the edge of the PC because otherwise it's known to increase the epithelial healing across the IOL. So I don't want those cells which are going to stick on the lens. Those cells I don't want them to proliferate at an early stage.
I agree with you. Actually, anterior capsule polishing is not really advisable much because it also causes asymmetric fibrosis. You may be able to clear it more in one area and less in the other. So I think it's better to leave it alone.
Yeah, and also a little opacification of the rim will prevent the negative dysphotopsia, because if it's absolutely clear, that's where you get the temporal reflex from. So anterior polishing, the way we were taught earlier, we are not so particular about it now. So I think the key excellent demonstration of surgeries and the key take home points are centration, which is matching your central reflex to the corneal first Purkinje reflex, overlap of the rexus, and removing the visco behind the lens. Yes. And I think the tight hydration of wound is also important, because
more than the tight hydration, you need the PC to stick to the IOL. So you should have adequate hydration of wounds, but not you can't overfill the chamber so that the actual IOL starts coming up. So if you're actually doing a tight hydration, many a times the fluid goes behind the IOL and pushes it up. So you need to tap the IOL behind after you have done the tight hydration, and then hydrate it again to the level that you want to.
Sure. Thank you, Dr. Desai. Any questions from the audience?
So the indications for CTR is many a times when you are doing capsular, rather irrigation aspiration of the cortex, you would realize that the bag is moving in the circumferential area. So it's a loose bag. So these are the patients in whom you would put in a CTR, because what we have seen 10 years back and not done, we are seeing those IOL bag complexes dropping down. So this is as a precautionary measure. That is one. The second indication is in IOLs like Zeiss or maybe Lucidus or certain other companies, I don't know the names, but they have a shorter length. So they range from 10.4 to 11. So toric IOLs especially. So if you have a bag which is big, like in high myopes or a high wide to wide, you would put in a CTR there because you want to decrease the equatorial size and the rotation. You can prevent the rotation.
Yeah, so very high myope, sometimes you can see once you've put the lens and you're doing hydro or you're doing the last eye of your vitreous, you see the lens rotating and you know that there's a lot of space. So high myopes, large bag, that's an indication that you can put a CTR for the stability of the lens long term. Yeah.
So there is no true value to the bag. I have seen that even in the normal diopters, I have that issue with the smaller IOLs and they do rotate. So we've had patients in whom we have done a re-rotation for IOL, and for the second eye we've put in a CTR so that it doesn't rotate.
So now I'll invite Dr. Ritu Arora. She's an eminent cataract refractive surgeon from Delhi, always very ready to adapt and evolve with the newer technology. She also calls her teaching programs now LEAD, which is learn, evolve, apply, and discuss. So that's something to look forward to. Dr. Ritu.
Thank you so much. I'll be talking about managing post-op refractive surprises. It's definitely something that we don't look forward to. So we know refractive cataract surgery now, the patient's expectations are really sky high, and partly it's our own fault because we as doctors overpromise spectacle-free vision. So we are so much in competition with our, peers and neighbors that, we all like to tell the patient that you're not going to need glasses at all. So although the advances in technology, IOLs and machines, and much better understanding and assessment of biometry has helped us to get there, and almost, like I would say, most of us, 85%, are within plus minus 1 diopter, and 55% patients have been shown to be within 0.5. But what we need to achieve, the target that we really need to achieve to hit the bullseye, is that 91% should be within 0.5 and 100% of our patients should be within 1 diopter. So what do we understand by a refractive surprise? It's basically a failure to achieve the intended post-op refractive target. So that means when you're counseling the patient, discussing with the patient, you do come to target, what kind of refractive, do you want to leave them emetropic, or you want to have a little bit of myopia? So you are discussing that with the patient. So if there's any difference between what we have pre-op planned and the post-op result, and the error is, say, more than 1 diopter, we'd call it a refractive surprise. And basically, the problem is that there becomes a gap between what the patient's expectations are and what the result is. Now, even a previously myopic patient whom you've counseled, who's gone for a monofocal lens and is 6'6", you think you've done an excellent job. The patient is very unhappy the next day because he can't look at his WhatsApp without his glasses, which he was used to earlier. So if you've not had that discussion with your patient preoperatively as to what they need to expect, such patients can be very unhappy. And multifocal lenses that we are trying to use, EDOFs and trifocals more and more, they are extremely sensitive to even small errors. So how do we manage these refractive surprises? Of course, the pre-op counseling I also already spoke about, and certain preventive measures, having a standard protocol, analyzing our cases and doing corrective steps then. So never promise spectacle-free vision. Always say that there'll be a reduced dependency on glasses, and always specify. I've started saying that it is dependent on machine measurements and individual healing. So I always tell my patients it depends on how your eye heals. Now you can't promise them that each and every patient is going to be perfect. So it's better to put the onus on them. So I use that line very clearly, that it depends on the healing of your eye, and that no eye ever has a zero power. So you'll always have a little bit of 0.25 or cylinder or sphere. And fine tuning with glasses may be required. And sometimes I think now, we've got in our consent form also a line saying that glasses may be required after surgery. So taking preventive measures is extremely important, especially where you have risk factors. So those are those high hyperopic patients, high myopic patients. You have to be much more careful about your biometry. Repeat it, as was said by my previous speaker. Call them on another day. And do tell them also that, these machines are only estimating it. They're not 100% calculating. There's always, a little spherical deviation in your measurements. Treat the MGD, the dry eye, that can cause a lot of variation in your measurements. Ask them for a history of refractive surgery. And wherever you're thinking that there could be ectasias or dystrophies or pentacam tomography is important. I end up doing a lot of vitrectomy, post-vitrectomized eyes, which have silicone oil. So again, you have to be very, very cautious in these cases, as you can have refractive errors. And long-term contact lens users, you need to ask them to stop discontinue their lenses before you do your biometry. And any patient who's an outlier, who has a very steep cornea, flat cornea, deep anterior chamber, and all of them, the formulas that we use, the effective lens positioning that we estimate goes a little wrong. So these cases again can be cases where you could have refractive errors. And of course, if you have a subluxated cataract, pseudo-exfoliation cases, or you have a zonular dialysis per-operatively, you see that. So again, that could be a risk factor. So the preventive measures would be doing a very accurate biometry, doing the biometry before you do any intervention. Optical is of course ideal, but if not, then immersion is equally good. And you must always measure both eyes. Even if the patient is pseudophakic in the other eye, always take both eye measurements and see if there's any difference in the axial length in both the eyes. So these are the conditions in which you would like to repeat your biometry, and always use two different methods if possible. So even if we are doing optical, we also do immersion. Or you can, if you have two, very lucky to have two optical biometers, then do it on two machines or on two separate visits. And a correct IOL selection using the right biometry formula depending on the axial length, depending on whether the patient has refractive surgery, using the online toric calculators. For me, Barrett Suite is my go-to for all cases, but I also use Hill RBF. I find both of them to be extremely accurate. Of course, there are many more newer formulas. If you have access to them, that's great. And then always select your refractive target, and this has to be with a discussion with the patient. So some lenses you need to choose the closest minus, and some lenses you would prefer to choose the closest plus. So another thing important is, of course, with our NABH, we've learned to have a surgical safety checklist and a timeout. You must confirm it's the correct patient. You could have two patients of the same name in your OR. It's the correct eye, because sometimes the patient you may have planned the right eye, but the patient feels his left eye is worse, and he may be telling your pre-operative assessment at the pre-op area, your technician, that no, it's this eye to be operated. So that should be confirmed. The correct IOL is available in your OR. And of course, you must also know your incision site and planning, and put up your toric IOL sheet. That should be displayed. Surgical perfection goes without saying. We are all excellent surgeons. But sometimes if you have very hard cataracts, you have a burn, you have overhydration also is a problem, or you have a leaky wound. Rhexis has already been spoken about, and IOL centration has also been spoken about. Sometimes in small pupils, you may have an asymmetric haptic fixation. So always check that your haptics are both in the bag. And if you end up having a zonular dialysis, use a CTR, use capsule segments. In case you get a PCR unexpectedly, you can do a reverse optic capture. And of course, always remove the retained viscoelastic. So if you do have a problem, what do? You need to analyze. Sometimes you have such an obvious problem that on the first post-op day, you know something has gone wrong. Otherwise, if you do have some minor refractive error, you have to wait for 2 weeks for the refraction to stabilize, and do the refraction yourself. Look at the patient's records to see if there has been any error. Some data entry and error could have taken place. If the patient is unhappy, discuss the options. If the patient is not complaining, manage the patient conservatively with glasses. Always do a dilated refraction, check your IOL position, look for capsular distension syndrome, look for any subtle corneal abnormalities that you may have missed. And of course, if you've not done an OCT, do a OCT post-operatively to look for any CME or any other, ERM or juxta telangiectasia, which could be a reason for a refractive surprise. But always hold the patient's hand, reassure the patient that you can provide a solution, because you must always let them feel it's a teamwork and that you're, with them. The patient will not go hopping, and you won't have other doctors telling them what went wrong in your surgery. So tell them that anything that happens can be solved, that the right time, the right cost has to be conveyed to them at the right time. So corrective steps should be taken depending on the magnitude of the error, the attitude of the patient. Patient could be happy, you could be unhappy. I remember I had one toric patient. I was unhappy because the patient had an error around 1 diopter. I corrected it, but the patient was still unhappy. Although, the post-op refraction was better to my satisfaction, but patient felt that no, whatever was done on the first time was, comfortable. So look at the status of the other eye. Suppose the patient is, you're doing a monofocal, suppose not even a premium, or you're doing an EDOF, and the patient has a little bit of a surprise. You could manage that in the other eye, and the patient could, with both eyes, be quite a satisfied patient. So always do a good refraction and repeat the biometry to see if there's been any error on that. So your correction could be cornea based. As we said, we could do a PRK, LASIK, or a femtokeratotomy. This is good if it's a small error, less than 4 diopters. Of course, for hyperopes, as we know, LASIK is not really very good. But the advantage is that if you have any higher order aberrations, that can be corrected at the same time. It's also very safe in patients who come to you late, or if you're getting a patient from someone else's refractive surprise. If the patient has already had a YAG capsulotomy, of course, you don't want to go in and do an IOL exchange. Disadvantages are that there could be dry eye, it's additional cost, and you need to see the corneal thickness, of course, if the patient has had a refractive surgery earlier. The lens-based options would be an IOL exchange, a piggyback. We do have Indian lenses available from the care group called Sulcofix. You could also use phakic IOLs as a piggyback IOL. And in case you have toric lenses with a refractive surprise, then the astigmatismfix.com is the option. So these are good for large refractive errors. And in the early post-op period, the same wound can be used. It's less costly as you're doing it in your own facility. And there are no induced aberrations, no additional dry eye. So for IOL exchange, there are different options available. You can use these IOL cutting scissors. You can, cut it into 3 parts, or you can twist and turn and remove it. There are various methods. And the piggyback IOLs, of course, the advantage is that, your intervention is very minimal in such cases. So here I'll just show you one of my cases, who's a 65-year-old female who had MGD and allergy. So she had a relatively small pupil. Right eye, we did a EDOF lens, and we put in a 23.5. Unfortunately, there were 2 patients who had similar names. And the first day when I saw her, I was shocked to see that her vision was only 6/36, and she had a refractive surprise of plus 3.5 with a clear cornea. And when we checked our records, we found that 2 patients, Naseem, Fatima, Banu, so that Fatima thing got mixed up and the wrong biometry sheet was attached. So we took up the patient for an IOL exchange. After 2 days, and we put in a 26.5 IOL from 23.5. So first you need to dial the haptics out. In such a case, use a good viscoelastic. Stabilize the lens from the side, because if you don't hold the lens with the microforceps, it's very difficult to cut these. So here I've cut it almost 90%, but you can even do half, and then you can dial it out, or you can cut it into 2 or 3 pieces and then remove the lens. So it's quite easy actually. These lenses are soft and you can get a very good result. So as I said, astigmatismfix.com is really a godsend for your toric lenses, and you can analyze, you can enter your post-op refractive data in that, and then you can compare what is the current location of your toric lens to what the patient's manifest refraction is, and then the analyzer would tell you whether rotating the lens would actually help. Not all toric lenses can be, the refractive surprise can be corrected just by lens rotation. So whether you want to rotate the lens or you want to do some other top-up procedure can be, better in such cases is to go for a LASIK or a PRK. And the second video that I'd like to share with you is this patient who was 60 years old, diabetic, and I'd already done a left eye toric for her. And right eye, I had planned a toric, which was a T4 IQ at 115 degrees. And on the first post-op day, the patient had a 6/18 vision with a refractive surprise at 15 degrees. So when we did the keratometry, I dilated the patient, and then to my surprise, this was the first time it ever occurred with me, was that the axis was at 15 instead of 115. So, I always make it a point to announce in the OT. The sheet is there, but I also announce to my assistant what is the lens alignment. But somehow my mind must have wandered away, and instead of marking 115, I marked 15. So, of course, this patient I took up the very next day. And this was very simple. I didn't put in any viscoelastic. I just opened up the side wound and realigned the lens. And we've already discussed in detail how we should be doing the alignment. It's always important to leave it 10 degrees, a little short of the final alignment. Then make sure you seal your wounds well, as Dr. Abhijit already explained to us. Once you've sealed your wounds, then you can do the final, fine tuning. So this patient then had a good result, had a refraction of minus 0.25, and the axis was well aligned. So in conclusion, I would say prevention is always better than cure. Pre-op counseling is good to set the patient's expectations. Do a careful biometry, IOL selection, and a surgical timeout is very essential to prevent any avoidable errors. The barrier to 100% success is definitely predicting your effective lens position, and also the fact that we get IOL powers only in 0.5 diopter steps. And those cases which are high-risk cases, as we discussed, we need to counsel that there could be a surprise in such patients. And we would still await to get the light adjustable lens where we can make post-op refractive adjustments. Once they are available, maybe life will be simpler. Thank you so much.
Thank you, Dr. Ritu, for such an exhaustive cover. I think we've practically touched upon all points. Any questions? So I think we can conclude the session, and thank you for attending and being a part of the session. Thank you.